how we can draw in expertise from both of our countries, our great universities and hospitals in both countries, but how do we come up with a plan to deliver a sustainable healthcare system for the future? And that's where KUKA is really, really important as a convening function, but with some specific priorities. We know that non-communicable diseases are on the rise, and we know the WHO has told us that actually the biggest burden for non-communicable diseases, probably 80% of the burden, will be in low and middle income countries. We know that that's what demography will tell us. So unless we have a solution for prevention, for treatment out of hospital, and how we use the new digital technologies to deliver healthcare of high quality that's sustainable where people need it, we will have failed. The other area that's absolutely critical to all of this, as I mentioned, is workforce. How do we have a sustainable workforce? And by workforce, I don't just mean training more doctors, although doctors are important, but it's how do we upskill our community health promoters across Kenya and also in the UK. I think the UK and the NHS has as much to learn from Kenya as vice versa. So this is a genuinely a mutual learning experience. How do we deliver healthcare in the community at low cost, but of high quality? And I think without considerations of workforce, none of this becomes possible. And so the areas we've chosen to focus on in the first instance are cancer, and it's great to have the introductory remarks from the chairman of the National Cancer Institute. And I had the privilege of meeting the chief executive who's here today, Professor Elias Melly, about how do we scale out the fantastic work on esophageal cancer that you'll be hearing about today and tomorrow, that was driven out of the University of Manchester and the Christie Hospital across the whole of the country. It's already been done in a number of sites in Kenya. And again, Richard and George and Gorogi, who are here, will talk about that. But how do we ensure that that prevention of esophageal cancer, the journey we started on 5 years ago, is available to everyone in Kenya and the whole of East Africa, using it as a model if it's a successful model. We're now also working on the prevention of kidney disease. I'm a kidney doctor by training before I became a pretend politician. And the WHO has said there are 300 million people on the continent with chronic kidney disease, but they don't know about it. And we're not going to be able to give them all kidney dialysis. We're not going to be able to give them all a kidney transplant. So unless we diagnose and prevent chronic kidney disease from becoming end-stage kidney disease, there will be a tidal wave of death across the continent. And the uplifting message is we know how to do this. We know how to diagnose early-stage kidney disease. We know how to prevent it. We have drug treatments that are actually very, very cheap that prevent the progression of chronic kidney disease. So do we have the wherewithal to bring about systems at modest cost that prevents kidney disease? And that's one of the priorities of the government of Kenya that we've been asked to address through KUKA. And then also antimicrobial resistance, as is in your as in the conference pack. We know that climate change is an accelerant of AMR. So how do we work with, particularly with the partnership at Kembury, to prevent the development and the increasing emergence of antimicrobial resistance that could actually undermine all of the efforts we make in our healthcare systems. So we have lots of partners in the room. More partners are joining. And I think as we convene KUKA in Nairobi, in Kenya, in London, in Manchester, is how do we bring all of this together into action? We've done a huge amount already on very little funding. It's been brought together by people's good wishes and bringing in grant support, and that's absolutely fantastic. We need to keep doing that and keep doing more of it. But really what we need is substantive funding to bring these dreams and early steps into real fruition, because people in Kenya and also in the UK are getting sicker and dying of lack of access to preventative treatments, lack of access to clinical trials. We don't have a workforce that's sustainable. So how do we really align across our governments, our universities, our hospitals, and our partnerships to really provide a model for sustainable financing into action for the Kenya-UK Health Alliance? And our aim, we know what the question is. We have our Nobel Prize question of our three aspects of a healthcare system. The aim for the next 3 days is how do we take KUKA as it enters the second half of its first decade that both of our governments have signed up to. How do we make KUKA into something that's even greater in the next 5 years than it's been in the previous 5 years? So once again, I will finish by saying thank you so much for your hospitality. Thank you so much for all of the hard work that everyone in this room does on a daily basis to support the work of KUKA, actually for very little, if any, reward other than it's the right thing to do. We had a vision in 2019 that's grown over the last 6 or 7 years. And I think we now have taken the first faltering steps to making that vision a reality. And I think the reason that we're here today is how do we accelerate our progress based on very, very firm foundations, which is always about the people that contribute their time, energy, wisdom, support, and kindness to a very, very important and I think a noble endeavour. So I will stop there. Thank you very much for listening. Asante Sana.
Yeah, thank you very much, Graham Lord. Why are we so muted? Let's have a round of applause for him. It's a wonderful, wonderful opening speech, and it just sets the trend, the pattern for expectations. He mentioned investment is going to be the direction we are moving in, and that's where actually rubber meets the road. But as we get to that destination, I'd like to take this opportunity to introduce to you our next opening speaker. Just give me a minute. It's Professor Njoroge. Professor Njoroge, please welcome to the floor. Thank you very much. Round of applause for Professor Njoroge. He is a winner. He is an award winner, very famous. You've seen him trending. He has won so many awards for this Kenya. He's a very proud Kenyan. Come on, round of applause for him. Thank you. A protocol allows me to introduce to you the CEO, also of the National Cancer Institute, Dr. Elias Melly. Please come forward, take the podium here, and it is your forum. I'm wondering why you're keeping a back seat. Please, Professor, I have a seat here whilst you wait on Dr. Elias to introduce you formally. Thank you. Round of applause for Dr. Elias Melly. He's one of the reasons why we're here to address matters cancer. Thank you.
Thank you very much. All protocols observed, our distinguished guests, all the invited guests, all the participants, good morning. I would like to begin our session by appreciating the opening remarks from our two teams, representation from the Ministry of Health from the Kenyan side by the Chair National Cancer Institute, and the UK part of the KUKA by Dr. Graham Lord. Thank you very much. That has set the pace of today's meeting. As introduced, my name is Elias Melly, the the CEO, National Cancer Institute of Kenya, who is one of the great partners in planning and execution of this meeting today. I have the privilege to have met part of the KUKA team in the previous visits within the country, and I want to congratulate the KUKA team for the great work that has happened over the last 7 years now. And already we have seen the fruits of this alliance between the two countries that have had bilateral engagements for decades. In the interest of time, I'll quickly give us a short overview about the cancer landscape in Kenya before I invite our panelists who are going to further engage and deliberate on this panel this morning. As mentioned by the chair of the National Cancer Institute, cancer is one of the emerging diseases in our country that has severely affected our healthcare system. And it did refer to the pillars of a healthcare system as guided by the World Health Organization. It is a disruptive disease that has affected all of us individually, as a community, and is now a global challenge. Hence the reason why we are here today, highlighting it as one of the major challenges that we have in our country and our region. It is one area that would require a multi-stakeholder, multi-country approach if we had to deal with this disease and reduce the burden. In one slide that I have this morning, I would want us to focus on this guy who is carrying this heavy load. And if you look at that load, it is too overwhelming. It reflects exactly what happens to our healthcare systems and what cancer is doing, among many other challenges. You will appreciate that in developing countries, we are still struggling with communicable diseases, the HIV, the malaria, the TB, but unfortunately, we are being hit hard with non-communicable diseases, and cancer is one of them. We know climate change plays a very critical role, in causation. And today and tomorrow, we will be having different topics that looks at cancer care through the entire continuum. From what challenges are we facing at prevention? What challenges are we facing at early detection? What challenges are we facing at diagnostics, treatment, into survivorship? And what strategies and intervention that can be anchored through KUKA, so that after this meeting, we will be having very clear way forward on how the cancer ecosystem can benefit from the KUKA, in our country as we learn from best practices from developing countries. Statistics, data do not lie. It predicts what exactly, is the burden. In our country, we have more than 44,000 cases of cancer every year. And this is data which is estimates from Globocan. We do believe that this data could be underestimation. And that is why the National Cancer Institute has taken a very robust strategy to establish the National Cancer Registry that is going to document the true burden of cancer in our country. I want to believe within the next 2 or 3 years, we should have collected every collectible cancer-related data in our country. The burden is so huge that our system cannot absorb it currently. If you look at mortalities, more than 29,000 cases every year. This is huge. And our major challenges is late presentation. Our major challenges is investment that would address the challenge through the entire continuum of care. The Ministry of Health has developed very robust policies which the National Cancer Institute implements And one anchor document that we have is the National Cancer Control Strategy that has 5 pillars that informs how, as a country, jointly with all the stakeholders, beginning with our hospitals within the country, our academic institutions, our research institutions, civil society, we are looking at the role of our partners in industry, pharmaceutical companies. We are looking at international community, professional association, and different arms of private sector. We are coordinating this entire stakeholder team to make sure that after 5 years, we should be seeing changes in the statistics that I've presented here today. We are investing a lot as a country, and over the last decade, there is so much that this country has achieved, and we should appreciate the dedicated leadership from the Ministry of Health, from the government. Our president, he's more focused than never before to make sure that cancer is addressed comprehensively in this country. Prevention initiatives that we have will be dissected by the experts who are seated here today. In terms of investing in early detection, screening programs across the country, we are focusing on major screenable cancers, cervical cancer, breast cancer. Those two are actually contributing more than 60% of mortalities amongst our women. If we focus on these two cancers to make sure that we detect them early, we prevent them, then ultimately we are going to reduce the burden of women cancers by 60%. Prostate cancer, cervical cancer, esophageal cancer is one of the rising cancers that, if it is not treated, 90% of our patients will die within the first year because of challenges including malnutrition. And I want to appreciate the investments through KUKA that has gone into research efforts to find ways of addressing this esophageal cancer. We sit in the clinic. I have the privilege to continue doing active clinical practice. And when I sat in my clinic this Monday, half of my patients were patients presenting with a diagnosis of esophageal cancer. Unfortunately, most of these patients, because they present late with complications of nutrition and complications of getting quality treatment, we end up losing them. So as a ministry, as a country, working with all of you, including our partners, we are hopeful that the engagements that we've continued having through KUKA, beginning with the programs which were led by Kenyatta University Teaching and Referral Hospital, can now be scaled up to the entire country so that the entire country can benefit from these programs. I know we have our academic institutions that are leading in research here. I have seen friends and colleagues from Egerton University, from Moy University, from Kisii University, and from our leading treating hospitals, national and county hospitals here. We are dedicated to make sure that we work as a team to make sure that we detect cancer early, to make sure that we diagnose cancer properly. The weakest link that we have in our entire cancer continuum of cancer care is diagnostics. We are at an era of precision oncology. We are at an era of biomarker-driven, interventions. If we had to treat cancer using either surgery, radiation, systemic treatments, novel therapies are now the key interventions in treating cancer. Nuclear medicine comes in. So in terms of treatment, we as a country are interested to make sure we onboard this in our institutions. And I want to believe that through KUKA, since it's a Kenya-UK alliance, we should be able to make this as a reality as we move on. We are now looking into survivorship. There are patients that are now surviving because of improved investment that 10 years ago, they would die. There are patients through our access programs, they've been able to access current interventions that are life-saving, but there's still more desired to be done. And we are looking at this Kenya-UK Alliance as one of the front runners in providing these solutions. We are also then looking at when patients survive, what challenges comes with survivorship. Breast cancer, cervical cancer, prostate cancer, they go through a lot of challenges. And at the heart of all this care we would like to improve, research plays a very critical role. Data is our new oil. And therefore, we would have to make sure that we use our data to conduct research that solves our local challenges. For a long time, we have relied heavily on foreign data. And sometimes this, underestimates or overestimates. And if it informs diagnosis or treatment, we may underdiagnose or overdiagnose, undertreat, or overtreat our patients because we are using foreign data. This is the time when, through this alliance, we should have robust clinical trial sites in our country to conduct research that solves challenges that we have as a country. The only hope is through partnerships, collaborations. And this is one example that we are citing today. As I conclude my remarks, I am very hopeful and optimistic that through the investments that have gone into our country, we need to handle the quality aspects. Because if we do not address that piece, it doesn't matter how much investments that we put in place. And this is heavily dependent on our human resources in cancer care. So professional development, continuous professional development, additional training programs through fellowships, through PhDs in basic sciences, clinical areas is very key, including training at the community level. As we implement universal health coverage, cancer is at the heart of it, and our focus is shifting from curative now to preventive. What are we doing in our communities with the support of including our community health promoters who are our first level healthcare workers now in our country? So ladies and gentlemen, I look forward to a discussion that is going to be intriguing, that will provide a lot of solutions. By the time this conference comes to an end, we should be sensitized more and we should be having a clear framework on how we are going to work between Kenya, UK, and other partners amongst our academic institutions and our treatment centers to make sure that cancer care is not going to be a challenge in our country as we move on. So ladies and gentlemen, to further discuss this session, allow me to invite distinguished speakers to join me up front here, led by Professor George Njoroge, who had stood up front, one of our own, very celebrated. We are excited as a country that has been a light in cancer research in general and cancer of the esophagus specifically. Welcome, Prof. I will give you an opportunity to dissect. Let's give a round of applause as he comes forward. Allow me also to welcome Professor Richard Cohen from Christie Hospital in UK. Kindly, if you could join us up front. Let's clap for Dr. Richard Cohen as he joins us. Allow me to also invite Dr. Amit from AstraZeneca to join us in this panel as well. Can we clap for him, please? These three gentlemen are going to prosecute a very important topic this afternoon. And I'd like to give them the mic in 2 minutes to just introduce themselves and share with us a little bit on the experience they've had with cancer care in their respective environments and how they think. Let me begin with Professor Njoroge. Since he is our own, he has the local context and has worked very closely with the UK team. Welcome, Prof.
Oh, thank you, CEO. And thank you, everybody. Thank you, Rod Graham, for being the founder, there in the founding of KUKA. I feel very proud that I became part of this KUKA. Yes, a lot has been said, but it's so important to understand that we are talking about a disease, esophageal cancer, where prevalence and mortality are nearly equal, 99.3%. That means if you are diagnosed with esophageal cancer, chances that you succumb to the disease are like 99.3%. So that's a death sentence. So when we got into this project back in 2022, we wrote a proposal which was reviewed positively among many proposals that were written. And through the leadership of Graham Rod, it was awarded the grant that you have been seeing in the newspapers. They are saying I got 446 million. I didn't get that money. It went all to research. So don't come to me asking me to give some of that money. So I was very excited when this grant was awarded. By profession, I'm what I call a drug hunter. I have discovered medicines in hepatitis C. I worked for Merck, Sharp and Dohme, Eli Lilly, and other pharmaceutical companies in USA. But when I came back to my country to give back to Kenya, I decided to embark as a director of research at KU Referral Hospital and also as a board director at KEMRI. So I was very happy to work with my colleagues at University of Manchester. This is a manifestation of a partnership that worked pretty well. We put together a group with very defined aims, and we wanted to know why people are dying so fast from esophageal cancer. 99.3% is so high a number. And the reason was when patients present themselves to their primary doctor, what happens in normal circumstances is that they have a heartburn, a sore throat, they are given a cough suppressant or some pain reliever. But when they come back, they come saying, I can't swallow food. And that means cancer has already entrenched itself. They are either in stage 3 or stage 4. So we came up with the University of Manchester, learning from what they've done in Greater Manchester, and decided let's come with a way where we can have early detection. So we came up with a small equipment, an endoscope, but a very fine endoscope with a camera that you can look through the throat, the esophageal, and see whether there are some lesions, there are some changes in the cancer, in the cells around the esophageal. Interestingly enough, and I'm not gonna say because it's a long debate, we were able to first of all engage patients. And the way we did this is we adopted some work that had been done in Manchester, whereby we retrofitted a mobile clinic. We took a truck and had clinicians there with an endoscope, and we would go to, we identified or we nominated 5 counties, Meru, Kisii, Nyeri, Kiambu, and Nakuru. We just wanted to do this as a model study, and we would dock the truck in particular places. You know, access to medical care in Kenya sometimes can be difficult. So we wanted to get it to the availability of this medical facility where the machinery or where the people are. and we went there, and it was fantastic. The awareness was done through TV, radio, and also going to churches. And we were able to get numerous people coming for screening. Interestingly enough, we screened so many people, and we had now the ones that we thought through the questionnaire had the potential of having this cancer, they were put to the second part, which was now doing a very non-invasive endoscopy. And then if we found some lesions, then we would now take a biopsy with the microscope, with the endoscope, and just give it to our pathologist who would determine whether it is normal or whether it is cancerous. The results which we will be publishing very soon in various journals, because we had a very, very interesting outcome. We were actually able, although I wouldn't give the numbers here because we are lighting up some publications, we were even able to tilt the balance to see quite a number of cases in stage 1 and 2, which is very, very important. But more importantly, and this should be very clear, we were able to even see cancers that were not cancer yet, precancerous cells, cells that are just about to be cancer, but they are not cancerous yet. And what that means, as you heard the CEO say, if we can identify this disease at that very, very early stage, one, it would be very beneficial to the patient, the country in terms of the amount of money you use treating people in stage 3 and 4, and also now being able to now give the feedback, give the families that are taking care of these patients. So I'm very, very excited that this is a good example of how good partnership can work, working with the University of Manchester and Christ Foundation. We have very interesting outcome, and we think now with the track we have, we can extend it to other counties. And for NCI, we will be providing them with information that they could put as a policy, because this is a very easy way to detect esophageal cancer. So it will be beneficial to the country and to all of us. And we'll continue doing this, not only in cancer, also in other diseases. Thank you very much. And I will give I think my colleague, Richard Cohen, might add a few things that I have missed, and or just say hi to our people. Thank you very much.
Prof, before Richard Cohen speaks, let's clap for Professor Njoroge for being our lead scientist. Thank you very much. So just to put this into focus, Professor Cohen, while you will be giving your remarks, I know the burden of cancer is rising globally, including in UK. Probably the approaches is what is different that impacts on outcomes. Kindly, you could also share on what do you think are the drivers behind this rising burden of cancer as you give your remarks over and above the esophageal cancer project. You're welcome. Can we clap for him?
Thank you very much. And first of all, thank you all for inviting me and my colleagues from the UK to this meeting. It's a great privilege for us to be here. Graham and I were here, and Mahesh, a few years ago when all this was starting, and to see the momentum we've built is absolutely wonderful. And really the purpose of this meeting is to talk about where we go next with taking this further. But to answer your question, I have to first of all say that standing here talking about esophageal cancer, I am rather a fraud. I'm an oncologist at the Christie Hospital, but esophageal cancer wasn't my specialist interest. But this whole came about when we started our collaboration with George and the colleagues. And I do remember when we were traveling around and we met certain leaders of different counties. And I remember one of the leaders stood up at a meeting and said he had never met someone who'd survived of cancer. And that really struck with me. And so when we talked about what project to do, esophageal cancer was the obvious ones to do for the reasons George has just explained. And so to answer your question about why are we seeing different incidences, well, our project hopefully will help answer that. But I will just make one point, and that appeared to be that when we looked between different counties, we were seeing different incidences of esophageal cancer, but also we recognised that there were different methods and resources available for recording esophageal cancer. And so one of the main points of our project was to set up a clinical outcomes unit which would uniformly collect data between all the counties. So hopefully, as we move this forward, the quality of the data, and so the true incidence, will become a little bit clearer, because I think we do recognise there's a variation. But two things we have done is we've done questionnaires to look at the environmental factors, and as we all know, certain factors have been described, such as very hot drinks and the tobacco and the alcohol and the poor diet, but also the genetics. And so in this study, we are also taking a genetic analysis of the esophageal cancers that we're seeing here, comparing them with esophageal cancers that we see in other parts of the world, and also between counties. So I'm taking a long way time to say I can't give you a clear answer now, but hopefully in the months and certainly years ahead, we'll have a much clearer idea. Thank you.
Thank you, Dr. Cohen. Can we clap for him? Now to Dr. Amit. My question to you is, where are we seeing the greatest strain in the healthcare system with regard to cancer care? As you give remarks on the role industry and pharma plays as a major partner in investment in cancer care. You're welcome.
Sure.
Can we clap for Dr. Amit?
Thank you so much. I represent AstraZeneca, and at the outset, I must thank you and thank the Kenya-UK Health Alliance for making me a part of the panel. Just one correction, I'm not a doctor. Wish I would have studied a little harder and cleared the difficult exams like my fellow panelists, but I did a very parallel stream. I did physics, masters, and then followed by an MBA. But a sheer pleasure to be here. Now, I'll talk about the role of the industry, and probably that's the reason that you have invited me to this elite panel. But I also want to tell you, your slides were very, very intriguing. The data that you presented, and I really like the way the data is disturbing, but you pointed out every hour deaths, which is very, very a serious disease to talk about it. Now, unfortunately, Africa is at a cusp of two different kinds of diseases. We have not yet come out completely of the communicable diseases. Of course, there is a huge progress which has been made. But unfortunately, we continue to grapple with those communicable diseases, and now we are on a volcano of a non-communicable diseases. Now, there was a data which was published by the Ministry of Health here in Kenya, which said that 43% of the all deaths of diseases is now with the non-communicable diseases. CKD and cancer, of course, are the one which are causing a huge amount of battle. Now, what you said also makes a huge difference, and I'll tell you what AstraZeneca is trying to bring in Africa. We started something which we call as Cancer Care Africa. We launched it in 2022 in Egypt. We launched this whole program in 2024 April in this country. Now, what you said for your organization, we have mapped exactly the same 4 pillars. And I'll just talk very briefly about. First thing is capacity and capability building. You know, we are a big nation, and the number of oncologists are handful. So how do we build that capacity? How do we build that whole capability, not only in terms of the medical treatment, but also in pathology? These are some of the initiatives which maybe during the course of time I'll go deep and talk about. 2 is early screening and diagnosis. Super important. You know, by the time a patient comes, and this is true for most of the non-communicable disease, cancer in particular. At stage 3 and stage 4, it becomes, the prognosis become very, very deep. So what are some of the markers that we can give? What are some of the tools which we can give even to the primary care physician so that we can have those early screening and diagnosis? I think that becomes. Third pillar is empowering patients. Sometimes we forget that there are people who become patients. So how do we create awareness about cancer and what all can we do so that there are some early markers which a people who is not a patient can understand that. Fourth to me, which is super important in this part of the country, is access to the innovative medicine. You know, the world has completely changed. The access that the Europe, the US, and the Western world is having to all those immunotherapies, targeted therapies is something which is changing the shape. People are now talking about remittance. So how do we bring that whole access to the innovative therapy by working with very closely with the stakeholder is the fourth pillar with the Cancer Care Africa. And I'm very happy that we are working very closely with your organization, with many of the private organizations, with the Ministry of Health, to make sure that with these four pillars, we from an industry standpoint can help to reduce the burden of the cancer. Thank you.
Great, thank you very much. And to my last questions to each of my panelists here, what strategies do we think we can use to address this rising challenge? We'll begin with Professor Njoroge.
One of the things we've done in our project is, as we said, we started with awareness and went to screening, and then we get people that are counselors, patients that are counselors, then we are doing something very, very important. As you said, diagnostics is very, very important, and we need some biomarkers. Right now, we are working with the University of Manchester again for our third aim, and because you ask a good question about risk factors. What are the risk factors? And if you go to Meru, people are saying people are getting cancer because of chewing mila. If you go to Bomet, they are saying it's because of drinking musik. If you go to Kiambu, they are saying you are getting cancer because of drinking hot tea. So nobody really knows what are the risk factors. And what we are doing right now is from people from Kisii, Kiambu, Nakuru, and Meru. We are now taking the counselors' tissues that we have. We've extracted DNA, and now they are being done what we call whole genome sequencing. We are seeing whether most cancers are due to either modification of the DNA or through the familial, from a family, inheritance of those genetic modifications. So we're going to figure out whether now we can get a biomarker. And if we can get that biomarker, we can use it like you use for diabetic patients, hemoglobin A1C. And if we have that biomarker, then we can test in the blood whether this person has the potential or is in a position to be getting esophageal cancer. So that's the directions we are trying to get to. Thank you.
Thank you very much. Professor Cohen, same question. Are there strategies the UK has used that we can learn from as Kenya to address this rising burden you could share with the participants?
Thank you very much. One aspect in terms of improving the outcome, and this was a real challenge in the UK, but not that many years ago, patients with cancer in the UK, the treatment they actually received could vary in different parts of the UK. Although there were national guidelines, different individuals did have slightly different approaches. And the introduction of multidisciplinary team meetings that occurred in the UK 15, 20 years ago, which were very difficult to implement. We're all very busy, and suddenly to get a number of health professionals in the same room to discuss cases at the same time is quite challenging. We have eventually got there, and every cancer patient now, their case will be discussed by a series of doctors, nurses, radiographers, people who are invested and know these patients to get the best outcome. And in this project, we have set up the multidisciplinary meetings amongst our colleagues for esophageal cancer so that we can start to ensure that there's a more uniform approach to treatment. So clearly, early diagnosis is crucial. Clearly, the etiological factors and the genetic factors are crucial, but also once the diagnosis is made, to ensure patients get an efficient and effective flow along a treatment pathway to use the resources to the best of their ability to the greatest benefit of the patient. So I think those are, and one final thing we have to talk about is this business of continuing to train, continuing to enable our workforce to be able to deliver the best quality of care.
Great, thank you very much. And finally to Amit, is there any hope for local manufacturing in our country as an intervention to reduce the cost of these innovative therapies? AstraZeneca is a big brother in the industry.
Sure. Thank you so much. I'll first like to touch on what both my fellow panelists talked about, I think, and probably a little deep onto the capacity and the capability building. I think I like what you said, Professor. We are also trying to interface not only the local capabilities here, but the cross-border capabilities. For example, we were trying to do a pathological workshop where we were trying to have a network of some of the evolved countries in terms of the pathology to make sure that we are able to get our biopsies much more better. So these are some of the things we are doing. I also like what my fellow panelists talked about, the local pathological report and the diagnostic markers. I'm very proud and happy to share that in this country, AstraZeneca tried to set up the first indigenous EGFR testing. We did that in partnership with Aga Khan Hospital, and also happy to tell that we have now also gone to the public sector where the Moy Teaching Institute at Eldoret is a part of the EGFR testing, something which you know is required for the NSCLC patients, a very, very basic test. We have moved on and we have now got 2 centers in this country up running with the NGS BRCA testing. Again, Aga Khan Hospital is one, and we have also recently partnered just few months before with the KNH, just to make sure that we are able to diagnose those markers, as Professor Yu was saying, so that more and more patients can be looked after. So the beginning has been there, and we have locally started, if not manufacturing, but at least local testing. And these were the samples which were not even tested here. They used to move out of the country. It used to take a lot of expenses and time. So that's something which AstraZeneca, thankfully, with collaboration with our partners, have been able to help. And I'm sure as we move forward, there are other opportunities in terms of the manufacturing that we are looking at. But I also want to tell you that these medicines, you are right, need that kind of access. And AstraZeneca is also running a lot of access program. And we are happy in case if people want to talk to more about us. Of course, we are present in most of the institute because that access initiatives are also a part of those 4 pillar strategy that I talked about.
Great, thank you very much. I wouldn't like to add much, but just to wrap up by appreciating my panelists and also looking forward into an impactful partnership and collaboration through KUKA to make sure that the areas where there are gaps in our healthcare system in general and cancer care, we could address them anchored through research, innovation, into local manufacturing and commercialization, because ultimately we have to find local solution for our local problems. And capacity building has been discussed heavily here, investment in prevention by identifying the etiology and also investing in diagnostics. These are priority areas that we would want to focus as a way of improving the outcomes of cancer in our country. I cannot end this without talking about innovative medicines. For a long time, we've treated our patients using chemotherapy, it is time that we transition, but we can only transition if we can identify the biomarkers. Ladies and gentlemen, there are many other sessions in the course of this. This was just setting the pace on the cancer discussions. But we have experts amongst ourselves here who are going to further discuss, dissect, explain, educate, inform on what is current, what have we discovered, and where are we heading to. Thank you very much. Have a good afternoon. Thank you to our panelists.
Thank you. A big round of applause for this wonderful panelists. So many things we learned during that session. I hope we're all taking copious notes because we're here to learn. And we're here to learn about cancer. You know, as Kenyans, cancers are still a mystique to us. The origins of these cancers. Why is it you lost a friend last week because of cancer? And we're still mystified. And I think we must use this opportunity, this platform, to understand the causes of cancer and some strategies, as was mentioned by the panelists, for prevention. So I'd like to call on Dr. Lucas to introduce the next panel. Dr. Lucas. And whilst he's doing that, I know we all want to breathe. I know we want oxygen. And this is what Wi-Fi presents. For those of us who do not have the Wi-Fi password, it comes in a suit where you go to, I think it's Jacaranda Hotel, and you insert 1963 in the first column. And in a similar vein, the password is also 1963. Yes? And for those of us who remember December 1963 as a very famous pop song, this should stay in memory. So without further ado, let me pass the mic to Dr. Lucas. Thank you.
Okay, let's see how well we follow instructions, okay? Okay? Can you hear me? Can you hear me? Okay. Rub your hands together. Just follow my instructions. Shake, 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 shake. Come on, rub again. Make a fist. Put it to your chin. Your chin is here. Right? Follow instructions. Your chin is here. So, for this moment, we have, let me allow the folks to come in. Okay, 1, 2, 3, come on. So for this moment, we're going to call, there's a friend of mine, and Helion has been very helpful to us, very supportive. It's a friend of mine, Dr. Eva Amwai. We go back a long time, and she is going to be coming. She works for Helion. She'll do the Helion, and then she'll invite the panel and have the panel discussion after this. So thank you very much. Come on, let's go.
Thank you very much. Habari zenyu? Hi. Good morning. Good afternoon. Is it good afternoon? Everyone look at their watch. Anyway, so welcome to the good part, which is the Helion part. So I'll just allow them to play the video of Helion, and then I will give a short presentation. Is there sound? Thank you so much. That is Helion. But I know when we're all looking at that, we're looking for brands that we can, associate with, right? That's a very global video. Now I want to bring it back home here in Kenya or Africa. Now, Helion, of course, as you've heard, is a global leader in consumer health care. And we have a clear purpose. The purpose is to deliver better everyday health with humanity. So we are the proud custodians of trusted brands like, now I want a drum roll here because you know the brand of, thank you very much, Panadol. Thank you. That was the reaction I was expecting. Eno. Thank you. Sensodyne and Aquafresh. Scott's. I know most of you are given Scott's as kids, eh? And many others. Calpol. Yes, Calpol. And of course, we are here in Kenya, and we've been here in Kenya for a while. A very long time, actually older than me. I hope that doesn't reveal my age, but we've been here for a very long time, and we are situated in industrial area, Likoni Road, just next to NTSA, at that big roundabout. That whole complex there is Helion Complex. We were formerly demerged from GSK in 2022, and now we are just a company independent 100% on consumer health. Now today, I'm going to focus on a part of our business that I'm very passionate about, and this is our responsible business, where we contribute to the community. So the first thing is our water stewardship. So all of our 24 manufacturing sites around the world are members of the Alliance for Water Stewardship, a global network that promotes a consistent and credible approach to sustainable water management, and this includes the Nairobi site. And tomorrow we are meeting with partners of Upper Tana Water Fund Trust, where we know that 95% of Nairobi's water, the water you use today morning, comes from Upper Tana watershed. So through our partnership with Upper Tana Water and Nairobi Water Fund Trust, we are supporting practical community-led solutions ranging from watershed restoration to sustainable land management. These interventions are expected to deliver approximately 76,000 cubic meters of annual water replenishment by year 3. The other one that I said I'm very passionate about, of course, me being a pharmacist, is AMREF partnership, where we formalized a partnership at the beginning of this year to advance community-led health initiatives that reduce the impact of malaria through prevention, awareness, and treatment interventions. The initiatives aims to reach approximately 75,000 people, including 200 community health promoters, 30 community health assistants, and 190 teachers, and around 45,600 school children, while strengthening the local health systems by training the health workers and integrating fever management and malaria prevention messaging in schools and health facilities across Siaya County. So Helion works in Kenya to demonstrate these partnerships because we want to make an impact and want to leave a footprint. I think that's the better part of my presentation. And I just want to say that Helion is here to partner. We're here for Kenyans, for Africans. We have not only one manufacturing site, but 3 in Africa, and also like that are Helion, one in Egypt and one in South Africa in Cape Town, and the others are CMOs. So we're here also to promote local manufacturing as much as we're here to support the communities. So thank you very much. My next duty will be to moderate the next session. Thank you. So I'm going to be moderating the sessions on global standards on emergency medicine, Kenya-UK partnership. And first and foremost, I would like to just welcome my panelists. If you're here, please come to the front when I call your name. So I'll start with Darren Walters. Thank you. And then I'll go to Andrew McLaughlin. Sorry if I... I'll go to Mr. Tim Hutchings. And Mr. David Mason. Clearly, you needed a lady for this moderation, right? Oh, no worries. I got you. So I think I'll start with a few questions, just so that we can set the mood. Not even start with a few questions, but I'll ask each of you to say something about the topic that you've been invited to speak about, and maybe you can share that mic. Or is it on? Yeah? Just a minute or two on the topic, and then we'll go into the questions. Maybe introduce yourself, the institute, and then we can go to the questions. All right?
Okay, thank you.
You.
For clarity, I'm Darren Walter. I'm from the University of Manchester, and I have a presentation to give to set out what we're terming visioning the delivery of emergency care. Emergency physician and academic in Manchester, been coming to Kenya for 4 years, and we feel like we're reaching a tipping point. And Kuka said, will you come and tell us about your tipping point? Drum roll.
Thank you.
Hi, I'm Andrew McLaughlin. I'm from the MIS Group. I'm one of the owners and managing director of the group. We come at this from more of a software side of things. So we deal with about 2/3 to 3/4 of the UK and Ireland's ambulance services, so 999. And we'll cover that in a little bit more detail in the presentations.
Sorry, I don't like using these. I don't know how. My name's Tim Hutchings. I'm also part of the MIS group. I'm the customer services director, but my background is 20 years operational ambulance service and command and control systems development. So we'll get into a bit more detail, but that's me.
Hi, everyone. I'm Dave Mason. I'm the Group Chief Technology Officer. My background is UK Defence, so I worked for big companies, Fujitsu, HP, and so on, in working for systems integrators in the defence industry. So about 6 years ago, we met Andy, and we decided to create something new in the sector to bring innovation into the ambulance sector and into the housing sector of the UK.
Thank you. That's quite inspiring. So, Darren, come and give us a perspective, and then.
Thank you very much. Ladies and gentlemen, I have a few slides, and I'm going to take 10 minutes, 15 minutes to run through emergency care. Now, we're here to talk about cancer and kidney disease. Where does emergency care fit here? I'm an emergency physician by background, and we believe we are the most exciting 15 minutes of everybody else's specialty. So we are where people appear when they struggle. We are the first point of contact. And it's really important from a patient's perspective that they get that experience right. Next slide, if you would, please. I want to start with a story. Take you back to 2023, 3 years ago. The World Health Assembly, unanimous decision, a call for action to strengthen health systems for delivering high-quality emergency, critical, and operative care, hereinafter called ECO. They created an acute care action network globally that has now got over 100 members to strengthen acute care delivery, implementing international standards. It needs to be multidisciplinary. It needs to involve the hospital staff, the community staff, the community health workers, and the public. 3 years ago, next slide. 4 weeks ago, they reconvened and they unanimously endorsed a global strategy for integrating emergency, critical, and operative care. It started 4 years ago. Next slide. It's a green light. The beginning is the most important part of the work. Plato said that 3,000 years ago. Right now, we have an opportunity, and we need to grasp it. So that's the global picture. Next slide. But we're not starting with a blank slate. Next. Kenya has an emergency medical care strategy. They've had one for 5 years, and I'm sure you won't be surprised to know it's moved rather slowly. But there is a scale strategy. There are some interesting principles in there that have some real potential. We're not starting from zero here in Kenya. Next. We have WHO with its emergency care system framework. I really like this. I was involved in Geneva in helping create it, but I want you to focus. Next. The little girl. When we talk about systems, we've heard this morning, networks, partnerships, research. Let's bring it back to the little girl who's been knocked down outside school. What happens? First things first, somebody sees it happen and calls for help. What help? Next. There needs to be somebody on the end of that phone line that doesn't say, have you got the money to pay for the fuel? That doesn't say, where are you? That says, we've got you, we're on the way. Next. Who is doing that? The emergency services. Police, yes. Fire, perhaps. But certainly the ambulance service. And my exposure to the ambulance service is that they are stretched, slow, and difficult to identify and locate. Next. We then got the ambulance itself. Does it come? Who's on it? What can they do? Are they caring for the patient? Next. They take you to where? To a hospital? Is that hospital ready to receive you? Next. And when you get there, who's receiving you? That little girl needs a patient journey. Let's talk about that. Next. Where we are is a chain of links. And when you Google links that are free, they've only got one broken link. I suggest to you, this should have a whole series of red links with breaks in it. Next. What we need is a solid chain that's reliable. So let me tell you how we're going to do it. Next. We need to get out there to the public. They need to trust us. We need to educate the public what to do, when to call for help, how to call for help. You are about to have a universal single point of access number for Kenya. 999 apparently is the number. Stan, tell me if I'm wrong, but I believe it's going to be 999. It needs to be free when you call. No questions about who's paying. And your SHA is looking at that. If, my experience in Uganda, if you offer to help, you must be guilty. Now, that may not be the Kenyan mindset, but it's the mindset in some parts of the world. If you try to help, you must be guilty of something. Many of us are Christian, and we are very aware of the Good Samaritan principle. Can you be prosecuted or found negligent for just trying to do a good deed? Is it legislated for? So we need to move there. We need to make sure that's right. But we need to know where you are. Did you know you can be tracked to within 3 square meters very easily based on your mobile phone here in Kenya? Yes, you can. Let's empower that. Next. So who's receiving this call? Do they do it in an organized fashion? In Kisii, it's a nurse with a pencil, a pad, and an old mobile phone. That's not robust, nor is it reliable. We need a system that says, where are you? That triages, prioritizes, sends the ambulance to your location and tracks it. Next. And then, ... There is a therapeutic vacuum. What is happening while you wait for that ambulance to come? Did some work in Manchester that discovered 85% of people would call for an ambulance. Yet only 10% of people will step forward and touch the patient. That's in Manchester. We have an issue. There are only so many ambulances. They're expensive. We need people to be willing to help. And when you ask them, why don't you help? They're afraid of doing something wrong. This is not rocket science. Next slide. Okay, is community first responders. WHO has just announced the plan for community first aid responders. The police should be trained. The fire service should be trained. There are various papers suggesting border riders. Some of them are the victims, and they've watched it happen to their friends. You can tell I'm not a singer, apparently. I'm not holding my microphone close enough to the top. Border riders, they witness it. What about lorry drivers, public service vehicle drivers? We should be training them. Public volunteers. And you may say, no, they won't volunteer. In the UK, in the northwest of England, we have 2,500 volunteers. And the ambulance service kits them out. Next. There is a WHO-approved curriculum. We are taking this through an official Global North accredited system, so they will get a certification for their training. It can be done in 2 days with no medical background. Do we provide them with kit? If only a pair of rubber gloves. But we can link them in and their mobile phone into the response network. They become a core part of the system until, next slide, the ambulance arrives. There are lots of systems, but we all have one purpose. We are trying to improve the outcomes for the patients. But what qualifications and experience do those ambulance crew have? What's their scope of practice? What's their standards and protocols? Staff, equipment. Next. If you have an ambulance, you have 2 people on it. If you want that ambulance to be on the road 24 hours a day, 7 days a week, you need 11.4 people. Now, I'm not quite sure how you get 0.4 of a person. So you need 12, but you need the extra 1 just to round it off for every ambulance. If you don't, you are going to have gaps. They should be safe. They should be awake. When I went to Kisii, they started their shift at 7 a.m. on Monday morning, and they finished their shift at 7 a.m. the following Monday morning. 168 hours on duty. You what? How on earth can they be safe and awake and responsive in that sort of environment? We need shift systems, we need oversight, we need monitoring. We need accreditation, we need training. Next. Kisii County got my message. We have trained 52 ambulance personnel so far. That's enough for the 3 ambulances they have. Stepping stone. Next slide. But optimal use would be at 70%. They were being used at 18% last year. They're sat there, the county's paying for them, they're not doing the work. Next slide. We need to understand their impact. We need data. Handwritten notes. No link to the hospital. No link to the system. We need reports. Next. We need standards. Well, in the UK, we have them. Kenya has started to have them. We need to mainstream them. Next. We need to link to the hospitals. Next. We need to train the specialists at scale and in sustainable fashion. And Kisii University has undertaken to do that. Next. With respect to the Emergency Medicine Kenya Foundation, they've been at this for 11 years. They started in 2015. Their goals are interesting and aspirational. Next slide. But they need a boost. The action plan has started. We need to turn what has been a gradual progress into an exponential one. Next. Next. Next one. Keep going. You will all be sat there saying, yeah, okay, nice idea. Who is this white bloke from Manchester who comes to tell us? But if you surround yourself with people who have ambition, it's infectious. Next. This is Kisii. Next. The first 3 chains, we need technology. I've brought 3 technologists with me. When we leave this conference, we are going to Kisii. The Kisii County Ministry of Health is looking at taking on board what they do. Next. So MIS is the solution. Next. From a staff point of view, next. We are going to Kisii University. So, Kisii University, Kisii County, right in the centre. There are lots of partners that can play into this. But please support us, please join us. We are here to tell you what we are doing in Kisii. This is not a concept, it has started. And we are going from here with our system to show you what it can do next week. But Kuka said, will you come and show what you've got that works here in Kenya? It's not a promise, it's here, and we are going to roll it out. And with that, I'm going to invite MIS Chief Executive to come up and show you what it does.
Thank you very much, Darren. I'll just give the slides a second to come up. Right, thank you. So I'm going to be talking about transforming emergency response across Kenya. What we're looking at doing effectively is providing a national response for a command and control system across the country, delivering faster responses, better clinical outcomes, greater accountability, and fundamentally also value for money, which we appreciate is very important in this setting. Who we are, though, is probably equally as important for yourselves, because you don't know who I am until we just announced ourselves. So we come from the UK. We're a family-run business. Myself and my brother actually own the company. We've been in this sector for 45 years. I haven't been in the sector for 45 years, just to put that one to rest. I've just had a hard life. But what we do in the UK is we work in the ambulance world, and we're looking, and we do improve emergency responses. We enhance the operational control, and we also support those clinical outcomes across that life cycle that Darren's been talking about. In addition to the more emergency side, we also do non-emergency care within the UK. So in the UK, we'll call that the 111 service, which is non-emergency. We also do a patient transport service as well, which is taking patients that need transferring across to hospital appointments, that sort of thing as well. So it's the full suite of ambulance services capability. Next, might need to jump through a couple. Jump through, Dave. In terms of our UK position, like I said, we cover the 999 and the non-emergency. We do real-time fleet and resource management. We have clinical safety integration. And we fundamentally provide an interoperable solution across the sector as well. And you can see roughly the regions that we cover in the diagram on the right. Next, please, Dave. We cover 41 million residents, roughly 9 million. Next, please. So we've obviously done the introductions of myself, Dave, and Tim. So you can come and find us and just have a chat. We're more than happy to talk about anything in that space. Next, please, Dave. Now here's the main point of where we've come from. We decided that the system we've got in the UK probably wasn't suitable for the Kenyan market. So we've gone ahead and actually created our own system specifically for this sector and for you guys. We call it Kestra. Our aims here are fundamentally we're starting with communications. So we provide a telephony, video and mobile app capability that will be available for the public. Next, please. We'll give you a command and dispatch system, which will give you real-time incident management. Next. Vehicle mobility. So we have an in-vehicle app that does live tracking, so we can see exactly where vehicles are, how far they've travelled. We do all the routing capabilities as well. Next, Dave. We're also providing hospital integration so that you can get patient alerts coming in. And you'll also see all of the notes and the capabilities and the treatments and anything like that that's come through so that the hospital can get an early arrivals schedule coming through. Next. We do resource and fleet management. So this is your workforce. So linking into what Darren said about shift management and asset management and optimizing the use of those to get to that 70% marker. Next. And we also have applied to this all of the international standards that we can think of, which cover both clinical quality, but also security as well, which is very much important to us. So we're going to try and do something potentially brave now, very quickly. We're either going to go with some slides, or if the Wi-Fi is actually good enough, we're actually going to show you the capability. So Dave's going to pick this one up now.
Okay, I have to be quick because of some timings, so I'm going to show you this as quickly as I can. But if anyone wants to see it in a bit, absolutely fine. Just tap me on the shoulder and we can run through it. So essentially, what we have on the dashboard, which will be visible for either a user or it could be a super user who's looking after a whole area, is we have here, a significant map of part of Kenya, and what we have are all the calls that we've raised in the test system. So these are all mapped on. As things change, these update in real time, and this is also where you'll see vehicles. So this is a live, real-time updating, in effect, map of everything that's going on, all calls and all vehicles. The way we've scaled it, we can obviously select counties and zoom around. I won't do it now because of time. We've built it to be multi-organisation as well. So where we see Kissi Ambulance, we're also looking at fire, police, could be Red Cross, could be any other capabilities. This isn't fixed to one system. We've created the ability to look at different services. So where Andy mentioned 111, we could have a 999 service, we could have a patient transport service, again, could have something for the Red Cross. Sorry? Yep, could have community healthcare. There's lots of options to this. It's been built as a platform to collect the requirements and work out and kind of pull it all together. So what I've done here is I've selected the priority, because obviously there's going to be high priority calls and lower priority calls. At the moment, I'm just showing all the P0s. And what I can do is I can drill into all the test data that we've created. And as you can all have a chuckle, this was us in the hotel last night creating calls in Nairobi. So this was us using our mobile app, and it really does pick the details down to a very, very fine level of detail in terms of where someone is. Again, sorry, no, it's okay. We've even got things like elevator. He carried a massive bag all day yesterday, and he's poor guy. We can also do elevation. We can do predicted floor levels. We can We've even got things like if someone's phone is plugged in or not, because all of these things matter in an emergency situation to try and help someone. So, conscious of time, before I get told off, this is the dispatch screen that we pulled together. So this is what we're going to be going through. This uses the WHO standards. Obviously, this is not a piece of paper, but this is our replacement for a piece of paper. The really key thing behind this is it removes the paper, digitizes the data, and then it can be used for other systems. All of the data that we will store in this system could be used for other purposes, for research, for screenings. There's lots of other things that we could use this data for. Obviously, we can see the call on the map, some of the cool stuff from a technical perspective, but also from an operational perspective. We've got a sequence of events. I doubt anyone can read this, but this is every single change that a person has made on these forms. Every map change, every change to the patient's status, the reason for the call, which goes to a WHO diagnosis process. Got 2 minutes. Sure. And the last bit on here is we also have real-time transcripts. So this is genuine real-time, so we see this coming in and other people can see this. As I'm being rightly hurried along, we also have a dispatch screen. So again, we've separated these into different roles. This is for scaling. Initially for Kissy, this is likely to be 1 or 2 people doing intake and dispatch. As systems scale over time, it could be different people doing different roles. What we can effectively do is we can see our call, we can see the details, we can see the coordinates and the what 3 words location, and we can pick an ambulance, pick a hospital, we can plot the route, which is just plotted to say, and then in effect we can dispatch that, send it to the mobile app for the responder. So, yeah. And the last screen, as I've been given a gentle nudge, thanks Tim, we also have an intake form built for the hospitals. So this is a view for the hospitals so they can see who is coming. So who is coming, who's inbound, who's arrived, and we also added an electronic patient record. This would be filled in on the mobile app by the responder to say, big details on the patient, clinical activity, observations, and so on. Apologies, that was so quick. Anyone has any questions, please ask us later. Thank you. No, it's fine. We haven't got a lot of time.
So thank you very much. Unfortunately, our time is spent. But why did I kind of feel I'm back into Chicago Med and ER with that simulation? It was really, really nice. I think we have a long way to go to be where the global benchmarking standard is, and we are hoping that we will definitely get there, and we fill in the gaps that we have identified. You have identified some gaps in your presentation, and I'm hoping that we will partner to fill in those gaps so that the Kenyan people can be able to experience really great emergency care systems, all right? So thank you. Let's give them a hand of applause. Thank you so much. I appreciate it. Over to the MC.
So, earlier today, I made a mistake. And this is how you know somebody from private sector and public sector. So I made a mistake, and I was supposed to introduce somebody because of seniority, and I screwed up. Big time. I apologize. You know who you are. I totally apologize for that. And at this time, I also did something that was a little bit off also. I forgot to invite the British High Commission to say something. So you see, it's about the sleep. That's my excuse for the whole day. Little sleep, right? So I'm going to invite Mr. Richlove to give us a word.
Good afternoon, ladies and gentlemen. A very warm welcome to those of you who have traveled from the UK and beyond to see us here in Nairobi. And for those of you who live in Nairobi, karibu sana. My name is Rich Labmensa, and I'm the Director for Trade and Investment at the British High Commission here in Nairobi. I also oversee our trade and investment work across East Africa. It is my distinct pleasure to join you here today for this very innovative conference. Let me begin by saying a huge thank you to the UK-Kenya Health Alliance, our partners across government, the government of Kenya, and partners from across the board who have brought us all together today and for the rest of the week for such an important coalition of researchers, clinicians, entrepreneurs, financiers, companies, and policymakers. Today's conference matters a great deal because the future of health will not be delivered by science alone, nor will it be delivered by public policy alone, nor by just businesses alone. It will be delivered where these worlds collide, where research becomes innovation, where innovation becomes investment, and where investment becomes a practical solution that improves lives, create jobs, and strengthen health systems. This is why this is such a powerful framing for our meeting here this week. This week reminds us that human health, animal health, environmental resilience, food systems, climate security, and economic growth are all interconnected. It also reminds us that the answers we need must be integrated, scalable, and sustainable, and not only scientifically sound, but also economically viable. The UK, like Kenya, to be our long-term partner of choice in health and life sciences. We say this with confidence because our partnership is already deep, practical, and evolving for the 21st century. It is rooted in decades of collaboration across research, clinical training, public health, education, businesses, and investment. And this is ably demonstrated here by the delegation that we have from the UK here this week. It is also firmly focused on the future, on growth, innovation, trade, jobs, and our shared prosperity. Under the UK-Kenya Strategic Partnership, our two countries are placing ever greater emphasis on science, innovation, technology, trade, but also practical delivery on how we can make a difference to our citizens. This matters a great deal for health, because health is not only a social priority, it is one of the most important growth sectors of the future. It will create the skilled jobs, support manufacturing, drive digital innovation, strengthen supply chains, and open opportunities, not just here in Kenya, but across the region. As I'm sure you know, I don't need to tell you this, the UK brings a strong and distinctive offer on this agenda. We bring world-class universities, research institutions, and clinical expertise. We bring the experience of the NHS and a very mature life sciences ecosystem. But above all, we also bring companies with capabilities across pharmaceuticals, medtech, diagnostics, digital health, specialist care, hospital systems, health infrastructure, and also professional services. And we bring strengths also in regulation, standards, evidence, data, skills, and health technology. Kenya, on the other hand, brings a compelling opportunity. It has a dynamic innovation ecosystem, a strong entrepreneurial culture, talented researchers and clinicians, ambitious healthcare reforms, and a growing private sector. And as I'm sure you all know, it's a gateway to East Africa. Kenya's ambition to become a regional hub for health innovation, manufacturing, and life sciences is one that the UK is ready to support. So what does this mean in practice? Well, let me tell you in 4 important points. First, it means backing innovation. We need to support UK and Kenyan researchers, clinicians, and entrepreneurs to create solutions for real health needs, from cancer care to kidney disease to antimicrobial resistance, climate resilience, digital health, diagnostics, supply chain, and emergency treatments. The best innovations, of course, will be those that are shaped by users, with evidence and designed for scale right from the onset. Second, our partnership means mobilizing the right finance. Good ideas need patient and transformative capital. Health systems need investment in infrastructure, equipment, data, workforce, and most importantly, service delivery. Businesses need finance that understand risk, rewards, innovation, and support long-term growth. That means bringing together public funding, development finance, commercial banks, equity partners, philanthropy, and corporate partners in more creative ways. And I think that underscores how important this week's conference is. The opportunity is not only to find individual projects, but to build an investable pipeline of companies, both UK and Kenya, and also the technologies and partnerships that are ready for use. If we can connect Kenya's healthcare priorities with UK expertise and right finance, we can and will unlock solutions that are both commercially sustainable and socially valuable. Third, our partnership means deepening technical collaboration. Trade and investment and our partnership works best when the enabling environment is strong. This includes having clear standards, trusted regulation, the interoperability of data systems, skilled workforce, procurement pathways, and intellectual property protection and predictable policy. These are the areas where the UK is keen to work with our Kenyan partners. We're keen to share our expertise, learning from Kenya's experience, because of course, no one holds a monopoly on knowledge, and co-developing approaches that fits Kenya's priorities. The fourth and final point is about building commercial partnerships that last. We want to see more UK and Kenyan companies work together, not only selling products and services, but also investing, manufacturing, and transferring the innovative technologies that will transform health in this century and beyond. Commercial partnerships should help reduce dependency, strengthen resilience, expand access, and create high-quality jobs both here in Kenya and in the UK. This is indeed the direction of travel we want to support, from aid to investments, from pilot to scale, from individual projects to ecosystems, and from good conversations to bankable, deliverable partnerships. The UK's role is to be a convener, a collaborator, a technical partner, as well as a commercial partner, helping bring together all the right institutions and the right companies with the right finance, having the right policy dialogue. This is why I have to emphasize again why this conference is so important. It is not simply a forum for speeches, so I'll be shutting up very soon. You'll be glad to hear, I suspect. This is a platform for deal making, for partnerships, and building practical problem-solving approaches to worldwide problems. I encourage you all here this week to actively use your visit here this week to meet potential partners, test various propositions, identify barriers, and ask what needs to happen in the next 10, 60, or even 90 days to move from ambition to actual delivery. The UK and Kenya have the ingredients to build a genuinely distinctive health and life sciences partnership, excellent research, strong institutions, and a growing investor interest and a common commitment to better health outcomes. The task now is to turn those ingredients into a stronger pipeline of investment, innovation, and commercial partnership. So my last message to you today is simple. The UK is here for the long term. We want to be Kenya's partner of choice for healthcare and life sciences, bringing choice in healthcare, innovation, finance, technical collaboration that will support healthier, more resilient, and more prosperous future for both our nations. Thank you, and I wish you a very productive, action-oriented session.
Thank you very much. Come on, a round of applause for our partners, British High Commission. They have been with us throughout. They've been part of our organizing committee of Kuka Conference, and let me acknowledge Madam Wangari. Mwangi, please stand and wave to everybody. She has been such a captain, yeah? If you ever want to go to sea or go to war, take this lady with you. She will drive the process. And we're very happy to have her. Thank you, sir. Thank you, Bonnie Richfield, for your wonderful contribution. And he speaks to partnerships. And it's partnerships that speaks to innovation, to research and development. And we want to move into a space where we can talk about investment, and that will be done this afternoon in a separate venue. But as we speak now, we are calling on the panel for local manufacturing. And with the help of Dr. Lucas, who is the moderator, you will come to the floor, Dr. Lucas, and introduce the panelists. But thank you very much. Thereafter, we will have lunch together. Thank you.
Okay, so lunch is about ready, but I have 15 more minutes to take. Just 15. 1, 2, 3, 4, 5. So let's, we're going to have, the next is going to be local manufacturing panel. We have 3 extinguished folks, and maybe maybe a fourth. That is Dr. Riek. Are you here? Dr. Riek from CDC, Africa CDC. Dr. Riek, okay, he should be coming up. And then we have Professor Graham Lord, please. And then we have Olo. I knew I was going to forget. It's the sleep. It's the sleep. It's Olekwala. It is a sleep, nothing else. So what we're going to do is quickly, and then if anyone sees Dr. Riek, he can join us at any time. We have a few quick questions we're going to do. There he is. I knew he was going to be coming. That's okay. So what we're going to do is very simple. We have different perspective here. I think a couple, there is research, there is local manufacturing, there is Africa viewpoint. We will give them 2 minutes each to say something from their perspective, and then I'll ask a couple questions. Now, if given a chance, I would like to hear so that we have a conversation together, especially now that the room is this, we don't have that many people. You all have very unique ideas that actually can share, they pollinate each other and get better. So I'm really looking for a very good way, and questions would be very good, how to ask and how to participate and share some of the ideas you have. Yeah, you guys know about local manufacturing, I'm sure. Okay, so we'll start with Dr. Riek.
A very, very good morning or afternoon, I believe. I'm Dr. Lul Riek. I had a privilege to work for Africa CDC. You are Africa CDC, which is the African Union Health Institution. When it comes to the local manufacturing, the Africa CDC define it as the next independent for African continent for so good reasons. And the first reason that we believe if Africa don't have ability to manufacture its own vaccines, if Africa don't have ability to manufacture their own medicines, own diagnostic, own health supplies, simply we don't have health security in our continent. And we have seen it not once, we have seen it multiple times during COVID. And we are seeing it now in our response to the ongoing Ebola outbreak. We have seen it 2 years ago during the mpox. For 1.5 billion people in our continent, we can't depend on the Western countries. And the sad is, for some of you that haven't the privilege to be part of the journey of the African Union, the Africa CDC, in February 2026, the African Union has endorsed Africa Health Security and Sovereignty Agenda. It has 5 pillars. And one of those pillars is access to the local manufacturing for our continent. And the good news is Excellency, the President of the Kenya, has been trusted as a champion for the local manufacturing. This is a journey that has started, but the biggest challenge for our effort is not external, it's internal. There's a divine sage. The biggest problem of the human being is self-belief, if self-doubt. If we in Africa, we will not believe that we can do it, it will not happen. It's not a lack of talent, it's not a lack of resources, it's not a lack of the will, it's a lack of self-belief. And that's the tragedy. And that's why the African Union came up with a very, it's ambitious, but it's necessary. 2040, at least 60% of African need in terms of the vaccines, in terms of the medical supplies must be manufactured in Africa. Why? It's simply because our Africa health security will not descend from heaven to earth. Africa health security will not be imported from any continent to Africa because it will not be sustained. It has to be built by people like you, people like me. Our scientists, I was so listening to some of the African scientists in this platform. They have what it takes. It's just a lack of self-belief. And it's a time for us to unlock, to believe in ourselves. Yes, it is possible. It is possible with our scientists, it's possible with our resources. It's possible with our regulatory systems that has been put in place, African medicines agencies. Because if each country is going to have the regulatory system, it's going to be fragmented and challenging. But if we have only one regulatory system, if Kenya came up with a product and pre-qualified by the African medicine regulatory agencies, so it can be sold in all the continents. We need to have also ability to Africans procurement process that has been launched, that Africa need to work together to have a procurement mechanism, pool procurement, that will give us ability to negotiate for good price, ability to buy directly from the manufacturing, reduce the cost, good quality, and all the country will have access to that market. That's what your Africa CDC is doing, and that's what will take us to what we call, the promised land that Africa will have ability to manufacture its own vaccines.
You took all my questions. I was going to ask you that as questions. Good. Thank you very much. Please don't take all my questions because I have questions for you.
Thank you. My name is Alan Olekwala. I work at the Kenya Medical Research Institute. It's based here in Nairobi. And I'm privileged to be here. Thank you so much for inviting us. KEMRI is a state corporation under the Science, Technology, and Innovation Act. And how have we gotten there? One of the reasons is through the years of research. Sorry about that. And also on top of that is we have a lot of collaboration and AMR. All these fall under the purview of KEMRI. And within Kemri, we have diverse things that we're doing. We are working towards vaccine development within the country. Somebody will speak about that, I think, tomorrow. We're also privileged to be working on school children deworming program, which some of the programs have been supported by UK partners. We have infectious diseases. We also have neglected tropical diseases, as well as non-communicable diseases as well. And on top of that, other than the research that we do, I work for a division called the Innovation Technology Transfer Division. And what are we trying to do there? One of the things that we're trying to do is to translate some of this research that is coming through to become products. And some of the products that we've worked this far as is development of immunochromatographic test kits, the normal strip test kits that you know, for Rift Valley fever, as well as for yellow fever and malaria as well. And this also has brought some of the issues that are bringing conversation around the room, because we have three key components: the R&D part, the research and development part. We have the optimization of these prototypes that you have developed, testing them in the field once you have developed them, because that's one of the key challenges we have. As our partner from Africa CDC has just said, we are importing over 90% of most of the medical devices that we're using. And on top of that, the production part, where as Kemri, one of the other things that we were trying to do is to look for strategic partners. As a government institution, we are limited in what we can do because government does not exist to make a profit. Government provides regulation and also support for some of the manufacturers. So one of the things that we are pushing towards is to help local companies come up with some of this. For the low-cost products, we are already doing that. I'm sure you've seen a lot of our disinfectants, our hand sanitizers in the space. But now we are moving towards the more technical aspects. One of the big companies, maybe I can mention here, is Revital, that is trying to partner with us on how to produce the panel kits that they can use for panel EQA, external quality assurance. So there is room. As an institution, we are ISO certified 9001. Under our department, we have ISO 13845, which is a certification for medical devices. And we also pushing to have ISO 20916, which is for clinical performance studies. As you know, clinical trials in this environment are huge. Chadox is one of the vaccines that we partnered with UK partners, the University of Oxford, during COVID time. And many are coming through also. So really, we think that the sky is the limit and Kemri is open. So I'm here to continue the conversation. Whoever would be interested in more information, we are around. Thank you so much.
Yeah, and my question was going to be how you move that to local manufacturing. How that all, because there's a lot of very interesting parts that you put together. But I will, just can think about that as we go on. And I will bring Professor Lord to talk about partnerships in local manufacturing.
Thank you very much. I think this is a very, very important session. And as you said, having different sort of groupings in the room to come to a solution. So I guess just to underpin what my fellow panelists have said, what are the three main reasons that you want local manufacturing? And then I'll just say 30 seconds about how partnerships can support that. The first thing, as you said, was about security. And by that I mean security of the supply chain. We've seen, and I guess it's also not just about manufacturing, I'd also sort of broaden it out into medical technology and sort of data engineering as well. We had an interesting presentation in the previous session about a technology solution for ambulance responses. Actually, those jobs need to be in this country. The people writing the algorithms, the people doing the data analysis need to be from Kenya. So that's kind of manufacturing. It's manufacturing medical technology, because actually what we see is convergence of the science of AI, technology, digital data with medicines. So actually we need to understand, when I talk about supply chain, it's not just APIs. I think the COVID vaccine was COVID was a very interesting, I don't mean in a good way, time for the global health community. And that's when I was working in Manchester, about a year after we founded KUKA. And many of the trials of what became known as the AstraZeneca COVID vaccine were done in Kenya and on the continent. And your health minister came over and said to me, I've just talked to your health secretary to ask for doses, and for a population of 50 million in Kenya, all the British government could give you was 150,000 doses. Just completely unacceptable, and shaming on the British government. Hopefully that's not acceptable. That can't happen again. It happened and it can't happen again. So actually what you said was so important. That's a difficult example, but that's the truth. So security. The second thing is jobs. Actually, if you build local manufacturing and supply chains, you have jobs. You have scalable procurement that gives jobs to your young people. And it's not just research jobs. In the UK, when you have one PhD working in advanced therapeutics or biotech, medtech, they create 8 to 10 other jobs that don't require a PhD or an undergraduate degree for supply chain. So there's a job multiplier effect, which brings about prosperity, which brings about civil peace. So that's very, very important. And the final thing, which is the world we've moved into now, is affordability. With tariffs and minimum pricing globally, mostly driven by our friends over the water, this is a new reality around how much people and countries have to pay for the drugs that they use. If they're made locally, you don't have to worry about any of that. So drugs can cost 1/10 of the price if they're made locally. How do partnerships work in that? How can KUKA help in that? I think partly it's about the convening power at scale across the multiple different sectors between British business and Kenyan business. And how do we partner that? How do our Kenyan policymakers make it easy for British companies to do business in Kenya? And vice versa. How can Kenyan companies come and work in the UK? And I know there's political will and alignment to do that. In fact, that was the main reason that the Kenya-UK partnership post-Brexit was built. That's why your former president came to London and spoke with our Prime Minister to say, how do we have global Britain and global Kenya in partnership again? So I'll stop there.
Thank you very much. So there's something that probably as a part that I want to add is that, and I think my friend Michael and I have had this conversation several times. How do I put this? African patients are never the primary customers of any medications being designed. Now that sounds a little problematic, but it's true. Think about it. All medications, where are they designed? What, if they're using, even if it's the prototypes of the receptor prototypes, even if they're like the electronic, they are modeled against what type of receptors? And then when the product is ready, how many of them are actually tested in Kenya or in Africa? So the folks who are here, medics who are here, extrapolate scientifically and use them locally. What am I trying to say? Genetics, pharmacogenetics, genetics, understanding who the African is. I mean, I think it is the least in terms of genetically. We are the least studied, least understood, and then we are the most diverse. So the dosing cannot be the same, I think. I mean, it's extrapolation scientifically, the dosing can't be the same. The extraction, the elimination from the body cannot be the same. But how do we work this? How do we understand this? How do we move this? And this is not they didn't ask me to do this. There's a company that I work for right now, I'm working with, partnering with, who has brought in a new drug into the country for breast cancer. And we are partnering to test, to go and talk to the patients who are getting these drugs, to understand how are they reacting to it. Then we are building, because then we get to understand how it works. And they're paying for it. And this is AstraZeneca. So they're paying for that to make sure that the patients who are getting it, we are monitoring what they're going through. But yes, we have to build that for ourselves. part of the concept of this conference was, how do we move from idea? Then you move from the idea, you put it up. So we look for what is a question from the patients, from the hospital, from the providers. Put it up for research. The institutions come and do research. Then we go ahead and innovate. The government has what they call industrial parks. Use those ones as incubation centers. Then we go back, make sure IP is done and everybody's intellectual property is properly protected. And then we now market it, and then you finish the whole cycle. That provides a pipeline for local manufacturing and for creation of wealth, jobs, and that is what this conference was about. So when we talk about local manufacturing, yes, there is nails and, you can talk about the machines and mixing things and APIs and all that. I mean, those who know, I think Dr. Eva Amwai may know this. What percent of APIs are procured locally in Africa? APIs, active pharmaceutical ingredients. How much? And sometimes it's just simple as medical grade starch or medical grade sugar. We grow what? Sugarcane, right? We eat what? Domas and all that. We have our own tubers that can actually can yield medical grade starch, but we import these things. Why? So anyways, that was local manufacturing. I'm sorry it was so short and quick because lunch is ready and I'm going to pass this to Mr. King to go. And actually before that, protocol doesn't work for me. Let's give a round of applause to all our panelists today.
Thank you. Thank you. A round of applause for the moderator and a wonderful panel. But please be seated. I know the greedy ones might be biting in various parts of the body, but lunch is ready. I would like to open the floor to ask any questions to the panelists that are here. Please, kindly.
Yeah, thank you very much. And my question or concern probably is outside cancer now, and it's about research and development of diseases for neglected diseases, quote unquote neglected, which for pharma industry does not make much money, which maybe we get those patients mainly around this area, around Africa. What can, and probably the AstraZeneca person can chip in if he can, what can KUKA do to help in that? A, increase the research in that area like leishmaniasis, etc. B, provide the drugs at reasonable costs, including, sickle cell, etc., that we see on day-to-day basis. Thank you.
Okay, you'll take that one? Yeah. Okay, so let me take the other one, then we can take them together.
Thank you. The question to the representative from the CDC. So you talked about the will within Africa. An equally impeding factor in this is research funding. A lot of these questions relate to research and research funding. If you think of how Europe is doing it, they've got Horizon Europe, which is almost the research engine for Europe, for research across Europe. So is there an attempt or an effort to create something similar to pump prime or even fully fund Africa-related research, whether it is technology, whether it's healthcare, pooling resources from across African countries? So there is like a Horizon Africa.
Thank you. Let's start with the first question.
Very good question. Let me give you a specific example. Obviously, drug pricing is beyond my remit, it's beyond my pay grade. I'm not going to get into that. Particularly now I've made some interesting comments about Trump's tariffs. I'm already in trouble with everybody. I'm not going there again. No, but research for neglected diseases. So you mentioned sickle. Actually, one of the hospitals whose board I sit on, King's College Hospital, has the biggest sickle population in the UK. So they're neglected around the UK in that sense, but actually, my physicians look after a huge number of sickle patients. We, King's College London, as part of KUKA, now that we're part of KUKA, worked with Afrexim Bank in Abuja to build a hospital. And they built a hospital and they said, okay, we need a research program in sickle because we have a lot of patients with sickle. So the Afrexim Foundation, both doing research in Abuja and in London with us, are saying, how do we get novel treatments for sickle at affordable prices into the population that we need? And this was 6 months ago. It led to a collaboration between the Afrexim Foundation and a startup company based in London that is looking at gene therapy cure for sickle cell being done in Abuja and in London at net zero price, essentially. So that's an example that we're doing now. I want to do the same thing in Kenya, in East Africa, with that same investment model. And that's how we can turn it around. And in fact, we're already looking through KUKA to bring that expertise in London and what we're doing with Abuja in discussion with the Afrexim Bank to Kenya as we speak.
Thank you. And also to add on to your question, one of the challenges we have in our area is that some of the material we have for raw material to begin to process some of the diagnostic assays, some of these, like the leishmaniasis and others, the genomic information is quite limited. A lot of ground has still not been covered. So some of this still needs to be worked on to get around it, because many of the manufacturers would not attempt something they are not familiar with. So this is some of the areas that we need to also work around. And on top of that, also our policies within our region, because you get taxed here in Kenya, you get taxed in Uganda, you get taxed in Ethiopia. As he said, if we can work on a modality where these conditions are favorable for the manufacturers, then it would make a lot of economic sense to them. Because I can tell you, it's cheaper for you to buy a diagnostic test kit directly from Europe or from Korea than to work with the local manufacturers on that. So as a country also, some of these areas are some of them that we need to try and have a conversation in the room to better improve and to better work around. Then lastly is our regulatory policies. How many steps does it take for you to get an approval, for you to sell within this country? So you find that there are good products out there, but they haven't gotten to the shelves yet, because a lot of the conversation is not within how best we can move these products out, but we are alive to that fact that some of our partners get to move their products faster. Some of the innovations are down here, but they remain in the research environment. Thank you.
Now, allow me also to complement some of your questions before I get into the other questions. I was born and raised in a country that I truly believe is the capital of the world when it comes to the neglected tropical disease. I worked for it for many, many years. So my advice, that's documentations. We need to do a really good surveillance to document the magnitude, the burden, the challenges that's related to the neglected tropical disease. Otherwise, they will always remain neglected, because it depends on who's seeing it. If someone from UK, from US, when you talk about neglected tropical disease, it doesn't make any sense to other than. So it's our moral opportunity, it's our moral obligation to ensure that we truly documented them. We publish those that will give the manufacturers, they can see the biggest picture that they can make money in that particular area. So let's work on documentations and let's work on publication. Coming to your questions on what the Africa CDC is doing in terms of local manufacturing. And I would like to say it with a word many years ago, a timeless wisdom from none other than Nelson Mandela. And once said, sometimes it falls upon a generation to be great. And let your greatness be blossoms. We are the generations that are facing multiple outbreaks. We are the generation that we have seen the Ebola, not once but twice. We are the generation that we have seen the mpox. And now we are also experiencing this Ebola. We have no vaccines, we have no diagnostics, we have no therapeutics. We have to pray and depend on the good wills of others. But when all things are equal, others will choose themselves than choosing the Africa. That's why having a local manufacturing ability for our continent is not negotiable. It's not for discussion. We don't need permission from anyone else. We must take it upon ourselves. We must learn from it. So it will not be possible unless we have an R&D. Africa CDC prioritized R&D as one of the top agenda, and we have the directors at the level of the science, which is buildings on the R&D. It's also not going to be possible without financing. We must also look into what we have and how we can be able to finance our research and development for the local manufacturing. We need to also to put the necessary infrastructure in place. Without infrastructure, also our vision will remain visions till when? Again, we need to work together. We need to avoid competitions among the countries. We have to regionalize our efforts. Africa is decentralized based on each region. Kenya is the capital of the Eastern Africa region in terms of the Africa CDC work. It has 14 countries. We have a disease priority for this particular region. We can work together and come up with the vaccine for those particular priority diseases. Those all are facts, but if we don't have will to work together, we will die all together as a, I don't want to use that word.
Can I just come on into just drawing the thread from what you asked to the comments you made, is that most, cancer vaccines, whatever, most therapeutics are tried and tested in clinical trials, as you said, in people that look like me. Okay? And we know that then doesn't work, or the dose is wrong, or it doesn't even work at all. I think one of the best ways of getting, whether it's for a neglected disease or a common disease, any disease, if the way that you get research into patient impact is through clinical trial infrastructure and testing out, hopefully with a locally manufactured product. I have to say, I think what I've seen, I think Rwanda has done very well in this space, but having a clinical trials network, because that's how you iron out variability in care. But that's also, you then identify which therapeutic works in your population. And actually, I think the most tried and tested way of driving research, innovation, manufacturing, commercialization, and improving clinical care at the same time is having a very, very robust clinical trial network. It's not expensive. We know how to do it. And it was something I was talking to Professor Melly when I was here in Nairobi in February. How do you roll out cancer trials? The new immunomodulators, the checkpoint regulators, do they work in the esophageal cancer that you see in Kenya? We have no idea. We better find out.
Thank you very much. Let's give a round of applause. And whilst we do that, there's one more question that Dr. Shem Ochodo would like to ask. Kindly, Dr. Shem, proceed.
Thank you very much. My question is to Africa CDC and KEMRI. Do the two institutions have a deliberate program to engage private sector and diasporas who remit into the continent, about nearly 100 billion sterling pounds every year in manufacturing, local manufacturing? If yes, or if no, is there any role that KUKA can play so that that can be realized, so that we go beyond just discussing it, but to getting it done?
Thank you, Dr. Shem. Ask the respondents to be very quick because the greedy worms are now complaining. Yeah, so I'm not certain. Who would like to respond to that question?
No, I truly believe the question is very, very relevant. If you look into what my response, we need private sector. We need to we need to put it in such a way that money can be made in local manufacturing. And that's the reason that we are involving and working closely with multiple private sector so they can see as an opportunity of making money, but also as an opportunity of bringing into the reality the health security for our continent. Again, our health will never be complete unless we have ability to manufacturing our own medicine, our own diagnostic. But most importantly, we need to change our mindset. If there's a paracetamol being made in Kenya, the Kenyan themselves, they may not even buy it. They want to buy something made in US, in India, and also. So those are the challenges. We must have self-trust for us to succeed.
Yeah, thank you, Dr. Ochuodo Shem. I think how first we would respond is, as Kemri, we are working with Africa CDC. We are a center of excellence for Africa CDC. Nairobi also is a RCC, the Regional Coordinating Center, just Dr. Lal has said. And on top of that, I think the way to approach it is, number one, I think this is a gray area for most of us in public sector, and we need to engage, and I need to acknowledge that there is a way to go around it. We can look at endowment funds, and also we can look at how equity can come off, especially for spin-off companies. As you know, Cambridge gave birth to BioVax, which is a vaccine manufacturing arm of government. So I think, Dr. Ochodo, beyond this, we can have more conversation around it. Thank you very much.
Yeah, thank you. Thank you very much. I hope, Dr. Ochodo, your question was suitably answered. There was one hangover question from Dr. Mahesh of Manchester University. Doctor, where are you? Yeah, where's Dr. Mahesh? He's here. Thank you.
No, thank you. I think I asked that question earlier, but I will take this opportunity to just put one idea into this. If KUKA needs to function effectively, if that is seen as a value, remember KUKA is Kenya, UK. So Kenya is primary. So that organization needs to be supported by Kenya. If KUKA depends on some grants coming from various places, it is not going to function effectively. That is the reality. So if it is Kenya, UK Health Alliance needs to function effectively, Kenya needs to think seriously and see how it can put pounds and pennies into it. Otherwise, it'll be a talking shop. Sorry, I'm a great believer of KUKA, but it needs to be said. But you know, if that expertise needs, I mean, it relates to that question about diaspora. How do you harness the diaspora? You need people. I mean, I'm from Sri Lanka. I used to be in Sri Lanka. The Sri Lankan diaspora did a lot in building post-conflict Sri Lanka to what it is now. And the African diaspora, I must say, has done a lot, but there is great potential to do more. And if that needs to be harnessed, Kenya and similar countries need to put resources into that. Otherwise, it will just be confined to an annual conference. I'm sorry if it is unpleasant to say that, but it needs to be said.
Thank you very much, Dr. Mahesh. And I can assure you, now that Cambridge has evolved as a university, it speaks to income generation. And as we sit here in the private sector, we know you've lived in the cloister for many years. You mentioned you've done this, you've done that. But the migration to the commercial space has been very limited. Now you have a different mandate whereby you have to generate income from your research findings and your activities. So we're here in the commercial space as entrepreneurs. They're all around you to give you the opportunity to engage. So as you emerge from the cloister, we will have an investment track this afternoon, and you can speak to that investment track. But in the meantime, I want to take the opportunity. Yeah, we will have an investment track later on once we have finished with the first plenary session, and it will be taking place in a facility inside the main hotel. In the meantime, it is lunchtime. We give thanks. Let us pray. Let us pray. We have no other than a deacon from the church, Madam Jetty, to stand up. Please come forward and bless the meal for us. You know, as we say, we're Africans. And religion, one person once said, is the opium of the people. So let us continue to consume our opium with the blessings that the Almighty referred to us. Thank you.
Thank you very much. I'm sure this one of mine is a pleasant one because people are tired and probably hungry. Let's pray. Our Heavenly Father, we want to thank you for this day. We want to thank you for this opportunity to come together and plan for how we can make our health better. You've given us something to eat. We ask that you bless it in Jesus' name.
Thank you.